Assalamu alaikum everyone. My name is Mohannad Awwad and I'm a second year medical student studying at King Saud University. And today we'll be discussing the anatomy of the spine. These are the objectives of today's lecture. So first we'll identify the cervical, thoracic, lumbar, sacral, and coccygeal vertebrae. Then we'll be able to differentiate between the cervical, thoracic, lumbar, sacral, and coccygeal vertebrae. Then we will also describe the vertebral curvatures. We will list the structures connecting adjacent vertebrae. We will list and identify the ligaments of the intervertebral joints. And we will describe the movements occurring in each region of the vertebral column. And finally, I will give you a little bit of the clinical correlation of the spine and why it is important to know the anatomy of the spine. Before we begin talking about each segment of the spinal cord alone, we should talk about the vertebral column as a whole. So the vertebral column is the central longitudinal bony pillar of the body. It supports the skull, the pectoral girdle, which is the scapula and the clavicle, and the upper limbs. It also supports the thoracic cage, and then by the way of the pelvic girdle, it transmits the body's weight to the lower limbs. It also serves a protective function to the spinal cord, the roots of the spinal nerves, and the covering meninges of the spinal cord. So from this definition, we can deduce that the functions of the spine is that it gives your body structure or its shape. It supports your body, which means it gives you your posture. It protects your spinal cord and it allows you to be flexible and move. The vertebral column is divided into 5 different segments. The upper segment, or known as the cervical segment, contains 7 vertebrae. The next segment contains 12 vertebrae and it is called the thoracic segment. And then we have 5 vertebrae in the lumbar segment. Then we have 5 fused vertebrae in the sacral segment, which form the sacrum. And then we have 3 to 4 fused vertebrae in the coccygeal segment, which form the coccyx. Altogether, in the vertebral column, we have 33 vertebrae. And each segment of the vertebral column has specific characteristics to its vertebrae, which makes it different from the other vertebrae, and we will be discussing these differences in this lecture. When the vertebral column is viewed laterally, it has a number of curvatures. We have primary curvatures, and then we have secondary curvatures. Primary curvatures of the vertebral column are concaved anteriorly, reflecting the original shape of the embryo, and are retained in the thoracic segment and in the sacral segment in adults. The secondary curvatures, which are concaved posteriorly, form in the cervical and lumbar regions, and they bring the center of gravity into a vertical line, which allows the body's weight to be balanced on the vertebral column in a way that expends the least amount of muscular energy to maintain an upright bipedal stance. The cervical curvature appears when a baby begins to hold his head, which is around 6 months. And the lumbar curvature develops when the baby begins to walk, which is around the end of the first year. This right here is the structure or basic structure of a typical vertebra. And this yoga position simplifies the basic structures that you need to know in this vertebra. So the body of the vertebra is the body here as well. And then from the body, you have 2 pedicles, resembled here as the arms. And then you have, from the pedicles, you have transverse processes. These transverse processes are resembled here as the elbows. And then you have laminas. The laminas are resembled here as the forearms. And then finally, the spinous process is resembled here as the two hands when they meet up. So again, we have the body, then we have the two pedicles, and then laterally from the two pedicles we have transverse processes, and then they meet medially to form the spinous process, and the bridge between the transverse process and the spinous process is called the lamina. And this right here is the vertebral foramen in which the spinal cord is found. And now that we have finished our introduction, we will begin talking about the cervical spine in much more detail. So, in this segment, we will be talking about the cervical spine. First, we will talk about the word origin, the cervical word origin, and then we'll be demonstrating the typical and then the atypical vertebrae. This right here is an anterior view of the cervical vertebrae. So we have C1, then C2, 3, 4, 5, 6, and then C7. And then this is the first thoracic vertebra with the first rib. The origin of the word cervical is derived from the Latin root word cervix, which means neck. So when I say cervical spine, I'm actually just saying that the vertebrae of the spine that are found in the neck. A bit branched off from what we're talking about today is a quote from the godfather of medicine, Hippocrates. He said that wherever the art of medicine is loved, there's also a love of humanity, which is well said. Now we're going to talk about the typical cervical vertebrae, which are C3 to C6. This means that the atypical cervical vertebrae are going to be C1, C2, and C7. So in general, the 7 cervical vertebrae are characterized by their small size and the presence of a foramen or a hole in each transverse process. A typical cervical vertebra has specific features, which are that the body is short in height, as we see here, and it is square in shape. And when viewed from above, its superior surface is concaved, and when viewed from below, its inferior surface is convex. And as we already said, each transverse process is perforated by a round foramen transversarium. So the name of the foramen in the transverse process is called foramen transversarium. The spinous process in the typical cervical vertebrae is short, bifid, which means it has two processes, and it is inclined inferiorly. The vertebral foramen is large and triangular. You might ask yourself, why is it large when the vertebra itself is small? Well, the vertebral foramen is large to accommodate for the spinal cord enlargements that occur in the cervical region. Then we can see that the facets are relatively flat. You might ask yourself, what is a facet? A facet is basically a joint in between the vertebrae in the back of the spine. So this right here is called the facet joint, and this one right here, and same goes to the rest of the spine. Facets on the superior articular process, so right here, face superior-posteriorly, means that they face up and back, superior-posteriorly. While the facets on the inferior articular process, which basically means here, face inferior-anteriorly, which means down and in front. To identify the typical cervical vertebra, You just have to look for the smiley face, as you see right here. Now that we've finished describing the typical cervical vertebra, we're going to jump right into the atypical cervical vertebras, beginning with C1. So the first cervical vertebra, or the atlas, does not possess a body or a spinous process. Instead, it has anterior arch, a posterior arch. It also has lateral masses. And on the superior and inferior surface of these lateral masses, it has articular surfaces. These articular surfaces articulate superiorly and inferiorly with bone. So on the superior surface, the articular surface articulates with the occipital condyles of the skull, forming the atlanto-occipital joints. These right here are the occipital condyles of the skull. Then the articular surfaces on the inferior surface articulate with the C2 vertebra, known as the axis, forming the atlantoaxial joints. The C2 vertebra, or the axis as we already mentioned, has a peg-like odontoid process, or dens. This right here is the peg-like odontoid process, or what we call the dens. This projects upward from the superior surface of the body towards the C1 vertebra. This right here represents the body of the C1 vertebra, or the atlas, that fused with the body of the axis during early development. And this right here serves as a articular facet on the anterior arch of the atlas. The C7 vertebra, or called the vertebra prominens. I always like to understand what is the reason behind naming of the anatomical structures, because it makes the memorization and understanding much easier. So for the seventh cervical vertebra, it is called the vertebra prominens. Prominens, when you think about prominence, it means prominent, or it is showing, or something like that. So the seventh cervical vertebra is the first vertebra that can be palpated posteriorly, as we see right here. So it makes sense that they call it the vertebra prominens, because it's the first prominent vertebra. The spinous process of the vertebra prominens is long and not bifid. So this is a specific feature to identify the seventh cervical vertebra. Its spinous process is long, it is not bifid, and the foramen transversarium is very small. The foramen transversarium in the seventh cervical vertebra only transmits the vertebral vein, unlike the rest of the cervical vertebras, which they transmit the vertebral vein and arteries. Now we're going to jump into the thoracic spine, and as we did in the cervical, we're going to talk about the origin of the word thoracic, and then we're going to be discussing the typical and atypical vertebras in the thoracic region. The word thoracic comes from the Latin word thorax, which means the chest of the body. So basically, when I say thoracic spine, I mean the vertebrae of the spinal column that are found in the chest area of the body. And again, a little bit branched away from what we're talking about today is a quote from Edward Jenner. He said that the essence of science is curiosity. And this is the basis of all scientific research. It's just curiosity. They want to know what's new. They want to explore new things. And I encourage everyone to explore and look for what's new in their field. The thoracic vertebra resembles a giraffe nicely, and this is a good visual for you to memorize the difference between the vertebrae. So, just as a recap, we said that the cervical spine, you have to look for the smiley face. And now in the thoracic segment, you should look for the giraffe. The typical thoracic vertebrae are T2 to T8. This means that the atypical thoracic vertebrae are T1, T9, T10, T11, and T12. The typical thoracic vertebra is medium-sized and has a Valentine heart-shaped body. So the size of the vertebra is not that big, and the body is shaped somewhat like a heart, as you see right here. It also has costal demifacets on each side at the posterior superior and inferior corners for articulation with the ribs. So a demifacet is just an indentation made from a bone on a bone. And costal means ribs. So this is the indentation that the ribs make on the posterior, so right here, superior and inferior corners of the body. So the ribs make indentations on the thoracic vertebrae superiorly and inferiorly right here. And they are not full facets, they are demifacets, so they are half facets. The thoracic vertebra also has small and circular vertebral foramen. The spinous process is long and inclined inferiorly, as we see right here. The transverse process have a costal facet for the articulation with the tubercle of the rib. So as you see here, the rib right here uh, in, has an indentation on the body of the vertebra, and then the tubercle of the rib also uh, indents the transverse process of the vertebra, forming a costal facet. The facets of the thoracic vertebra are relatively flat as well. The facets on the superior articular process face posterior-laterally, which means they face back and away from the midline. So back and right in this case, back and left in this case. And then the facets on the inferior articular process, which are right here, they face anterior-medially, so in front and towards the midline. In front and toward the midline. Now that we discussed the typical thoracic vertebra features, we're going to jump right into the atypical thoracic vertebrae, beginning with T1. So the first thoracic vertebra has all of the features of a typical thoracic vertebra, except that it has a full costal facet on its body, right here, and a costal demifacet on its inferior corner. And its spinous process is less inclined inferiorly. The atypical thoracic vertebrae T9 and T10 have the following features. So regarding to T9, it only has a costal demifacet on its superior corner, as we see right here, while the 10th thoracic vertebra has a costal facet, one full costal facet on its body. So the 9th thoracic vertebra only has a demifacet, while the 10th has a full costal facet. And just for you guys to remember that the thoracic vertebra looks like a giraffe. The 11th and 12th thoracic vertebrae have the following features. They only have a costal facet on their body, right here, and they do not have a costal facet on their transverse processes from the tubercle of the rib. The 12th thoracic vertebra has a special feature, which is that the inferior articular process is convexed and turned laterally. If you remember that the rest of the thoracic vertebrae, the inferior articular process was facing anterior-medially. You'll know why that the 12th thoracic vertebra has its inferior articular process convex and turned laterally in a while. Now we're going to talk about the lumbar spine. First of all, we're going to talk about the origin of the word lumbar, and then we're going to discuss the typical lumbar vertebra. The difference between the typical and atypical lumbar vertebras is very difficult for you to identify, and it will be left for the professionals. The word lumbar comes from the Latin word lumbus, which means loin, and for the meat lovers out there, they already know that loin means the meat that comes from the end of the back of the cattle. So I'm talking about the lumbar spine, I mean the vertebrae that are at the end of the back. And as always, I'd like to give you a quote from Joseph Lister. He says, next to the promulgation of the truth, the best thing I can conceive that man can do is the public recantation of an error. The lumbar vertebra resembles or looks like the head of a moose. So now we know that the cervical vertebra looks like a smiley face. We know that the thoracic vertebra looks like a giraffe. And now we know that the lumbar vertebra looks like a moose. The typical lumbar vertebra has a large kidney-shaped body, as we see right here. It has a large and triangular vertebral foramen. If you remember, in the cervical vertebrae, we said that it has a large triangular vertebral foramen to accommodate for the spinal cord enlargements in that area. And same goes here. Because there are spinal cord enlargements in this area, we have the large and triangular vertebral foramen. The lumbar vertebrae have a short, flat, and quadrangular spinous process, and the articular processes on its superior surface are concaved and rotated medially, while the articular processes on its inferior surface are convex and rotated laterally. Don't you remember in the 12th thoracic vertebra we said that the inferior articular processes become convex and rotated laterally? Well, this is called lumbarization of the 12th thoracic vertebra. Lumbarization. Now we're going to talk about the sacral spine. We're going to talk about the origin of the word sacral and the typical sacral vertebra. In my eyes, I see that the sacrum resembles a butterfly. You might ask why. These right here are called the ala of the sacral spine. And ala in Latin means wings. And this butterfly right here, the wings has a dotted pattern, which looks like the foramens in the sacral spine. So I see that the sacrum resembles the wings of a butterfly. That's why. The origin of the word sacrum comes from the Latin phrase "o sacrum" or sacred bone, and it was named this way because the large sacrum of animals was often a part of ritual sacrifices in ancient times. This is an interesting piece of information, to be honest. And as always, I'll give you a quote by Galen. He said, look at the nervous system as the key to maximum health, and you'll know exactly why next year in CNS. The sacrum consists of 5 sacral vertebrae that are fused together, which are concaved anteriorly and convexed posteriorly. It articulates superiorly with the L5 vertebra. It articulates inferiorly with the coccyx, and it articulates laterally with the iliac, forming the sacroiliac joint. The fused spinous processes form the median sacral crest. The vertebral canal continues inside the sacrum as the sacral canal, and it is opened inferiorly as the sacral hiatus. Finally, we're going to talk about the coccygeal spine. We're going to talk about the origin of the word coccyx and the typical vertebra. I myself see that the coccyx looks like a beetle, but historians say other than that, and we'll know what they say in a while. They named it the coccyx because they thought that the shape of the coccyx resembles the cuckoo's bill or the beak of the cuckoo. And as always, I'd like to give you a quote from Louis Pasteur. He said that the more I study nature, the more I stand amazed at the work of the Creator. Science brings men closer to God. And that is indeed true. The coccyx has the following features. It is consisting of 3 to 4 coccygeal vertebrae that are fused together. It articulates superiorly with the sacrum, and the coccyx has articular and transverse processes superiorly, but it lacks pedicles, laminas, and spinous processes. So, after we finished discussing all of the features of the different segments of the vertebral column, you now might ask yourself, how can I identify this vertebra? I'm in the OSPE and they bring me a vertebra in front of me. How can I identify this vertebra? So to identify the vertebra, first you must ask yourself, okay, what segment did this vertebra come from? Is it cervical, thoracic, lumbar, sacral, coccygeal? What is the shape of the body? The spinous process, the transverse process? And you should identify whether it's typical or atypical. Does it have any specific features that make you think, okay, this has a dens, and the only vertebra that has a dens is C2, so this is a C2 vertebra, and so on. So let's take this as an example. You're in your OSPE anatomy station and they bring this vertebra in front of you. I see it as a gift. So first of all, is it cervical, thoracic, lumbar? It's cervical. Why? Because you see here we have the foramen transverse area. Okay, now we know that it's cervical. Okay, I don't see any body, I don't see any spinous process, but I see an anterior arch, a posterior arch. Okay, all of these features point towards C1. So this is a C1 vertebra. Let's take this as an example. So, oh, I see this vertebra. It's smiling at me. We have the foramen transversarium. We have a bifid spinous process. We have a large triangular vertebral foramen. And you see the body right here. It is concaved superiorly. You, if you have a sharp eye, you can see that the facets on the superior surface face superior posteriorly, but they're not quite shown. So all of these features point toward this is a typical cervical vertebra from C3 to C6. So the foramen transversarium, bifid spinous process, a large triangular vertebral foramen. The body is concave superiorly, and if you have a sharp eye, you can see that the facets on the superior articular process face superior posteriorly. So all these features point toward the typical cervical vertebra. If I add the C7, the vertebra prominence, you can see the difference. First of all, you can see that the spinous process is not bifid. The foramina transversarium is smaller than the ones found in the typical cervical vertebras. So this right here is a C7 cervical vertebra. Let's take this one. Okay, this might be a bit challenging to you. So first of all, look at the body. If you see here, the body has a superior and inferior costal demifacet. So this means that this is all you think about thoracic. Okay, this is the thoracic. It has a superior and inferior costal demifacet. Okay. The spinous process is inclined inferior. Okay, that's a good sign. The facets on the superior articular process face posterior laterally. So all these features point toward that this is a typical thoracic vertebra, C T2 to T8. This one, let's take this one as an example. So if you have a sharp eye, you can see that there's only one full costal facet right here. The spinous process is quadrangular in shape. Okay, the spinous process is quadrangular in shape, but we said the spinous process that quadrangular shape is lumbar region. But this has a costal facet. How does that work? Well, I said that the 12th thoracic vertebra can go what we call lumbardization. So I think that this is a 12th thoracic vertebra, but let's see. Let's continue and see. Okay, the inferior articular facet is rotated laterally and it is convex. Oh, we said that this is a specific feature for the 12th thoracic vertebra. And we also see that the transverse process has no costal facet. So all of these features point toward that this is a 12th thoracic vertebra. Now we're going to be talking about the vertebral column joints. We have four different types of joints in our vertebral column. We have the atlanto-occipital joint, atlanto-axial joint, the joints between the vertebral bodies, and the joints between the vertebral arches. And we're going to be talking about each and every one in specific details. The atlanto-occipital joint is the joint between the atlas, which is C1, and the occipital condyles of the skull. We have several ligaments that are involved in the atlanto-occipital joint. We have the anterior atlanto-occipital membrane, which is this one right here. And then we have the posterior atlanto-occipital membrane. These ligaments help in stabilizing the atlanto-occipital joint. The second joint that we're going to be discussing is the atlanto-axial joint. The atlanto-axial joint is basically three synovial joints. One between the apex of the odontoid process and the anterior arch of the atlas, and the other two are between the lateral masses of the bones. We have several ligaments that are involved in the atlanto-axial joint. We have the apical ligament, which is this one right here. This is the odontoid process of the axis, and it is between the odontoid process of the axis and the basilar part of the occipital bone of the skull. And then we have the alar ligament, which is this one right here. We also have the cruciate ligament, and we have the membrane tectoria, which is right here, and it is cut. And here it is shown, the membrane tectoria. These all help in stabilizing the atlanto-axial joint. Just to make it clear, the three synovial joints that we have, the atlanto-axial joint, we have this one right here between the apex of the odontoid process and the anterior arch. And then we have between the lateral masses of the vertebrae C1 and C2. Now we're going to be talking about the joints between the vertebral bodies. Between the vertebral bodies, we have thin plates of hyaline cartilage covering the superior and inferior surface of the bodies of adjacent vertebrae. Sandwiched between these thin plates of hyaline cartilage is a intervertebral disc. The intervertebral disc is composed of annulus fibrosus peripherally and nucleus pulposus centrally. The physical properties of the intervertebral disc allows them to serve as shock absorbers when a sudden load is applied on the vertebral column, an instance if a person jumps from a height. So, as the car has shock absorbers, when you go over a speed bump, these are our shock absorbers. They absorb any shock that is applied on the vertebral column. They are thickest, so the intervertebral discs are thickest in the cervical and lumbar regions where the movements of the vertebral column are greatest. The ligaments that are involved in the intervertebral joints are the anterior longitudinal ligament and posterior longitudinal ligament. The anterior longitudinal ligament is found here, and the posterior longitudinal ligament is found right here. The joints between the vertebral arches is basically the zygophysial joints, and they are the facet joints that we discussed. The ligaments involved in the facet joints is the supraspinous ligament, the interspinous ligament, the intertransverse ligament, ligamentum flavum, and ligamentum nuchae, which is only found in the cervical region. And I'll show you these ligaments in the next slide. As we said previously, these are the vertebral ligaments that severely limit the degree of movement possible between the adjacent vertebrae. This right here is the anterior longitudinal ligament. Then this is the posterior longitudinal ligament. Then we have the ligamentum flavum right here. Between the transverse processes, we have the intertransverse ligament. Between the spinous processes, we have the interspinous ligament. And on the apex of the spinous processes, we have the supraspinous ligament. And on the zygophysial joint, we have a capsule as well. The vertebral ligaments are best seen via MRI. So right here we have the anterior longitudinal ligament. If we continue the anterior longitudinal ligament superiorly, it will form the anterior atlanto-occipital membrane. And then we have the posterior longitudinal ligament. And if we continue it superiorly, it will form the tectorial membrane. And then we have the ligamentum flavum. Superiorly, it will form the posterior atlanto-occipital membrane. And then we have the supraspinous ligament. And superiorly, it will form the nuchal ligament, which is only found in the cervical segment. The vertebral column movements. In the cervical region, we have extensive flexion and extension, which means flexion and extension, like you're saying yes. And this movement occurs at the atlanto-occipital joint. We have extensive abduction or lateral flexion, and we have extensive rotation, which occurs at the atlanto-axial joint. We also have extensive circumduction. The thoracic region movements are limited. It has limited flexion and extension, limited abduction or lateral flexion, very limited rotation, and limited circumduction. This is all due to the ribs, the costal cartilage, and the sternum, which restrict the range of movement in the thoracic region. While in the lumbar region, it has extensive flexion and extension, extensive abduction or lateral rotation, lateral flexion, no rotation whatsoever, and extensive circumduction. We can see that the extensive flexion and extension come from the shape of the articular process because they are somewhat on top of each other, which allow for the flexion and extension to occur, but they do not allow for the rotation to occur. So the clinical correlation of why to study the spine's anatomy is related to some degenerative causes of irregular curvatures of the spine, some disc degenerations, some tumors, traumas that can occur to the spine, and lots of other stuff. Some can be congenital, some can be acquired, some can be degenerative, as we said. So, on as an example, we have some abnormal vertebral column curves. We have kyphosis, lordosis, and scoliosis. Lordosis, we have normal lumbar lordosis in the lumbar region, but we have something called hyperlordosis, which means that it is pronounced. Same goes to the thoracic region. We have normal thoracic kyphosis, but it can become hyperkyphosis, which becomes abnormally pronounced. And then scoliosis is abnormal, sideways curvatures. Not only sideways, it can be in a 3D plane. We also have herniated discs that can affect the spinal nerves. We also have spinal cord compressions, spinal nerve compressions, tumors. We also have traumas like fractures, osteoporosis, spondylosis, and spondylolisthesis. So this is the pars interarticularis. In spondylosis, it is broken. In spondylolisthesis, the vertebra itself becomes displaced, which affects the alignment of the spine. These are the most common types of fractures that can happen in the vertebral column. So we have compression fractures, burst fractures, translation or rotational fractures, and distraction. The best way to view bone is via CT. So this is a CT scan, and we can see the vertebral column nicely. This is the a lumbar X-ray, and this is a cervical thoracic X-ray. At the end, the references that I used is the Atlas of Human Anatomy, Natter, 7th edition, Snell's Clinical Anatomy by Regions, 10th edition, and Gray's Anatomy, 3rd edition. Recommended channels, we have Sam Webster, Ninja Nerd, and Ken Hub. I believe that there are many more than these, but these are the ones that I personally use and I recommend. And at the end, I'd like to thank you very much for your time, and I hope that you benefited from this lecture. Thank you very much. This was Mohannad Awwad, a second year medical student, and I'll see you in the next lecture.